This is the Inside Track. We discuss health, healthcare, and medical insurance simplified. Powered by Total Risk Administrators and the TRA experts Warren, Alan, Dr. Avron, Rena, Jeff, and Kim. Sharp insight, real conversations. Let's go.
Hi everyone, welcome to another episode of the Inside Track. It's so exciting that we've hit the ground running this year. Our first two podcasts have gone out. Again, the response has been amazing, and I think we started well. So looking forward to episode 3. We've got some exciting content for you today. I'll leave it to Doc Avron to give you a bit of insight and do the introduction for us. And then after our interview, we're going to have a nice couple of Q&As that have come through, and I'll explain that when we get to it. But Doc, what did you get up to with our guest this week?
Yeah, well, I mean, we know we've had so many questions on exercise, right? And we know how important it is. So we said, let's go find the expert in South Africa and try and understand more about exercise, practically, theoretically. And I was very excited to be able to get Georgia Torres, who's associate professor and head of department of exercise science and sports medicine at Wits University. Very knowledgeable on this topic, and we had really a great interview with her, really understanding why is exercise medicine, why actually is it medicine, and let's have a listen to what she had to say.
Great.
Thanks for joining us today, Georgia.
It's a pleasure to be here. Thank you for having me. Thank you.
And if you don't mind, as we discussed through the show, I'm not going to call you Prof. Georgia Torres, so you can call me everyone. We'll just everyone, and I'll call you Georgia. But it's really special to have you on our show today. It's probably one of my passions as well, the topic we're going to be discussing. And we really wanted to title this podcast, Exercise is Medicine. And really, I wanted to ask you, what does that actually mean from a medical and scientific point of view?
It's quite interesting because I actually lecture the medical students at Wits too, which is quite it's quite an honor. But it's, in my eyes, it's quite simple. The doctors are taught about medicines they give to help health of their patients, from pharmacology, therapeutics, yoga, all of those things. They all considered medicines. And for a long time, we haven't seen exercise as part of this toolbox. And probably in my eyes, it's the most powerful pill you can give someone. And I think we're getting there, but we still don't recognize the pervasiveness of it. So when we're saying exercise is the medicine, it doesn't only mean that exercise can influence health outcomes, can influence health span, can influence longevity. I think what it also means is that it can be part of the management regime of other medicines, and it makes other medicines work well. So it certainly is something that we need to strongly look at and learn how we place it into health management and health as such, put it that way.
Right. So what you're saying is preventative health treatment regimes. It should be part of the treatment plan, right, of individuals. Exactly. And not just an adjunct.
Not only for prevention, not only for prevention, you're quite right, Avron, but also for treatment. You're quite right,
So if we move, that almost moves into the next question I wanted to ask you, that if exercise were a pill, what conditions would it be prescribed for?
So, and I know it sounds a little bit, what's it called? I'm trying to find the right word. Easy or precautious, or whatever you want to call it. But we have documented, for 36 documented, evidence-based documented, for 36 chronic diseases, exercise is a pill that has beneficial outcomes. Sometimes more when compared to either placebo or normal standard treatment of a disease or an event. But because, and we'll talk a little bit about this, because of the way exercise works, it can actually be prescribed across any any illness,
Mm,
and physical inactivity considered as one of those diseases or illnesses in my books.
right. Georgia, I know that there's been a lot of work done recently on exercise and cancer, and studies that have come out. Can you maybe just expand on that for our listeners a bit and our viewers to the podcast to understand that? Is that actually real? And what is the data showing?
So, in the last 10 years, I'd say there has been quite a push in exercise oncology, the use of exercise interventions in cancer prevention and cancer treatment, and as an adjunct to cancer treatment. So when you look at the prevention part of what the data is showing, there's no doubt that a review in 2023 showed that across 10 common cancers, including breast cancer, including prostate, the exercise prevents cancer as such. But for me, the more exciting part is what exercise does that prevents cancer and also during treatment of cancer. So there are two things that exercise does that's been shown through. We'll talk a little bit more about that, but through these things that are released during exercise called exokines. One is that it makes the microenvironment around the tumor unhappy, because what it actually does is it creates, firstly, extra blood cells that go to this microenvironment of the tumor. Now, a tumor does not like, it likes hypoxic conditions. It doesn't like oxygenated conditions. Exercise creates that and almost strangles the tumor by supplying oxygen. The other thing it does is that it releases a whole lot of immune cells, like our natural killer cells, like our T cells, and they actually decrease metastases, proliferation, and increase apoptosis, increase the killing basically of the tumor. So both in the tumor itself and the microenvironment, exercise influences both those things quite radically. The other thing that when it's used with, for example, chemotherapy and the anti-cancer therapies, what it does is it has a great effect on on mitigating and ameliorating the side effects of those anti-cancer treatments, the fatigue, the pain, the nausea, and big plus, cancer treatment comes with a loss, and cancer with a loss of muscle tissue. And that's where exercise plays a huge role in maintaining this important tissue that actually improves health and such. So there is no doubt, and I think in our country at the moment, it is gaining a lot of momentum. Last year, so the year before, we wrote a paper with Discovery looking at the progression of cancer, and it was found that it reduced the progression of cancer by 33%. If I haven't got the correct number, but around about that number.
I mean, that's just staggering, right? I don't know any other medication or besides going on to your chemotherapeutic or radiation therapy or surgery that can have that type of effect. I mean, that's just mind-boggling, that reduction.
And again, this was stage 1. The paper was around stage 1 cancer, so it wasn't, progressed as such. But that's the reason why we need to exercise before anything happens. Yes. And the great thing about that is you actually, and we'll talk about dose, but you need less exercise before anything happens. You need more exercise if there is a condition. But we'll talk about that.
Georgia, are we saying that exercise helps both in the prevention of cancer and the progression of cancer once you have it?
Correct.
Okay.
Correct.
And that's a very important learning point that we should take away out of this podcast. And we are going to talk about what that type of exercise means. But that may tie into my question of health span versus lifespan. And I'm sure you've read a lot about that. And there's a lot going on social media, etc., when you look at health span versus lifespan. But how does exercise help us stay healthy and functional for longer? So not just living longer, but healthy and more
Right.
functional.
Okay, so health span is obviously what we want. We want to be functional. We want to have the longest possible disease-free years that we can have. Now, how exercise improves health span is through the release of exokines. So when we exercise, there are molecules, proteins, extracellular vesicles that are released. There are signaling moieties that are released. Up to just over 8,500 molecules are released in an acute bout of exercise, and that's been shown by research. Those are released from different places in the body, from muscles, they're called myokines, from the liver, they're called hepatokines, from the adipose tissue, they're called adipokines. They're released from brain tissue, and they're released from, I'm missing one, bone. When they are released, they signal pathways just like a pharmacological agent. So they signal a downstream effects of this molecule will release that molecule, then that molecule will signal that molecule, and eventually things happen like, if you look at the heart, we form extra heart cells. Now I don't know of a medicine that can actually produce more myocardial cells. They can form blood vessels, angiogenesis, that move around a blockage or a place that's not working well. If you look at bone, they release myokines that help build bone and reduce the myoclasts that break down the formation of bone. If you look at adipose tissue, they, for example, irisin, they create more brown adipose cells, which are more oxygenated, they're more metabolic. And those in themselves then are not, they don't have the inflammatory effect of your normal fat cell. And
Sure.
that's this theory, to be fitter, fat and fit is better than to be unfit and lean. That's where the whole story comes from. So because exercise releases molecules that at the end of the day affect actual functionality of pretty much all our body systems, from endocrine to cardiovascular to muscular to endocrine to brain health. So, we can go on talking about how it influences the whole brain system and actually creates more brain cells and more dendrites in your brain, which is quite scary. But because of that effect, that outcome, it doesn't just affect the fact that I'm going to live longer. It affects that I'm going to live longer with functionality, because I'm improving the function of this organ directly, not
Right.
in another way. And that's the difference between, if you like, pills and the pill called exercise.
Yes.
Yes. Is there a side effect of exercise? Huge amounts, yes. Or you go and exercise when you're on antibiotics, when you've had a cold. Okay, that's it, all right?
Yeah, sure.
If you can call that a side effect, But there aren't the side effects that other medicines have.
Traditional
with
medicines
exercise.
have. Yes. I want to move on to the two big types of exercise. That's your cardiovascular and muscle strengthening, right? Let's start with cardiovascular. And we know the big talk now is VO2 max. All the companies are measuring it, medical aids are measuring, etc. Can you explain why VO2 max is such an important indicator in terms of our cardiovascular fitness as one of the key markers?
So a very long time ago, a gentleman, Professor Stephen Blair, showed, and that was a very long time ago, I think over 20 years ago, that if you compared someone with a low cardiorespiratory fitness, which is related to having a low VO2, so the VO2 is the measurement of cardiorespiratory fitness, the ability to do long-term exercise for a prolonged period of time. He showed that he looked at all sort of chronic diseases, hypertension, smoking, diabetes, overweight, high BMI, and this thing called low cardiorespiratory fitness. And he found that the low cardiorespiratory fitness attributed to the percentage of deaths far more than even if you put smoking, diabetes, and obesity all together. And that's where it all started in terms of now, why is this measure so important? And it's quite nice because just like blood pressure measure, just like cholesterol measure, just like a temperature, you have this thing that you can actually measure and use it as a dial of, actually mortality number one, and where is my health number two. And that's why they started doing that. They've also showed, for example, another study in the New England Journal showed that if you take people who have had cardiovascular events from either myocardial infarctions to bypasses to heart failure, and you do this cardiorespiratory test, you do a VO2 peak. In other words, you exercise and we make the exercise harder and harder and harder, and you go to a functional, a peak where you stop. That value at the peak, at the top where you end, that's your CRF value. Let's take it that way. So what they did is they went and compared unfit people who only reached, we call it a value of 5 meds. So we won't go into meds, but say that's the reading, right? And those that reached 10. And if you look at the people with cardiovascular disease, so they've got cardiovascular disease, okay, their mortality rate was lower than the person who only reached 5 meds but had no cardiovascular disease. And by half, it lowered by half, by 50%. That's the crazy thing is that even with any disease, you just change someone's cardiorespiratory fitness, you are changing their health outcomes. And they can stay with hypertension, they can stay smoking, they can stay with the high BMI.
That's incredible. So we're saying VO2 max is a measure of cardiovascular fitness, right? Yeah. So just explain to our listeners, what is it actually measuring? Your maximum oxygen consumption?
Yeah.
When you're at your peak heart rate?
Peak or your maximum oxygen consumption. Now, going back to your physiology, you'll remember
without going into too much detail and complexity.
So the FIC principle tells you that how you consume oxygen, so your VO2, how you consume it, depends on your heart function. So it depends on everything that's happening with the heart centrally, but then it also depends on peripherally how you get that oxygen to the skeletal muscles and how you extract it, which are your mitochondria. Now, the powerhouse of energy is your mitochondria in your cell, which, by the way, exercise is shown to make new ones and to eat the bad ones, just as simply as that. So when you exercise, you're actually regenerating the powerhouse, and that is the anti-senescent, the anti-aging power of exercise. So because of its measurement across a whole lot of systems, including central and peripheral mechanisms, I think that is why it's such a key role. At the end of the day, the longer you can produce energy, the higher your cardiorespiratory fitness, the lower your risk of mortality.
Right. And just the last question, which I'm often asked, the VO2 max measurements on your handheld devices, which a lot of us are wearing, and you also, I can see there, how accurate is that? Can we rely on that, or does one need to go to an exercise lab to get your VO2 max measured?
It is
for the average person out there who's exercising.
Yeah, absolutely, it is accurate. You have to, though, do it over a period of time, and you have to have a session that is at least, in my findings, at least 20 minutes long. So when you go for your longer walks, or it's not that great if you're using high intensity exercise to determine that VO2, but if you're doing a longer duration, like you go out for your bike ride,
Yes.
it is great. And what's important is that it gives you the zone. In other words, it's a great screening tool, like your finger prick with cholesterol, exactly the same thing. You'll know
Yes.
whether it's good, bad, or ugly. And more importantly is you can monitor its increase, its decrease, its maintenance.
And you can improve your VO2 max, which I think is critical. I want to go
Yeah.
on to muscle strength. We've spoken about VO2 max, cardiorespiratory fitness. The other big area of exercise is muscle strengthening, people working and strengthening their muscles. Is that important? Is it as important as VO2 max? And how does that impact your health span?
So I'd say in the last 5 years, that has gained importance, and studies, not as many as the cardiorespiratory studies, but there've been some real good studies that have shown that an increase in muscle strength, and a simple test like your grip dynamometer test, where your grip strength is a predictor of mortality, is a predictor of longevity. And I think why it's important is that strength does different things to cardio, or if you want cardiovascular workout, or aerobic workout, or endurance workout. The outputs or the outcomes that are different. For example, you're not going to get an increase in oxidative enzymes in strength training as you get in cardio, but you are not going to get an increase in the power output of the skeletal muscle fiber that you get in strength from cardio exercise. And I think those two interplay and do different things, but they both are at the moment being seen to be equally important. So if you look at the current recommendations for exercise from the World Health Organization, it says both. So you have to do cardiovascular and you have to do strength. And they added it in the last, I'd say, 5 years. So I think there's a lot more work that needs to be done. Like, for example, with strength, like, which types of strength.
Yes.
We know that low, moderate intensity cardiovascular and high intensity cardiovascular, and we know what they do. We haven't yet determined really, like, your Hyroxes, your high intensity strength, your low intensity strength, where you're doing 15 reps, or the guys that are doing a minute of reps. So we're still working that out, but strength is vital. And the other thing is that it's not just strength in the gym, Avron. It's body resistance strength. You go for your walk and then you stop at a tree and you do a push-up against a tree, or you do a lunge. So, or you do yoga, or you do dancing, or you do Tai Chi. So it's that strength that also has an effect on health.
Yeah, I'm glad to hear that.
Well, I don't know about the two of you, but that makes total sense to me.
Yes, it does.
The fact that just the introduction of exercise can affect some, the medical issues that you're dealing with. So I think that's great.
Definitely. I think we've always thought about exercise sort of as an adjunct, lifestyle addition, etc. But as we heard from the associate prof, Georgia Torres, is that exercise is medicine.
Yeah.
And really we should think about that in terms of our lifestyle.
Yeah.
And
we had so much good content, Al, that we're actually going to break it into another 2-part series.
Yes.
So, we've looked at now, to start, we've looked at the theory behind all of this. And in the next episode, we'll look at the practical side of how you introduce exercise as part of sort of a medicinal assistance. So
exactly. And to just tell listeners, creatine's coming up in the
creatine, absolutely. That'll come up in the next, and that's a hot topic. You may remember, those watching, from our first episode where we said we've actually consulted with the youth.
Yes.
We've actually seen what's important to the youth these days, and creatine came up. So I'm glad we've addressed that. We'll be addressing that in the next episode. But I think for today, and this will be our sector before we close, what we did is here at TRA, we're big on AI, artificial intelligence. It's we use that to our advantage as a business, And what we did is we asked our AI engine to really scout the market at the moment, scout societies, scout what's happening, and give us a sense of what are the questions out there regarding gap cover. So what we've had a nice nice response. We've got some questions that we've prepared, and these are again for our viewers. This is again gap cover 101. We did it last year. We're going to continue that. We believe in answering the questions that you would be asking. So this is for you. And this little section we call why gap cover is becoming essential, not optional. So we're gonna lean on Alan to give us all the wise answers here. But for example, the first question, many people still think that Medicaid alone protects them fully. Is that still true in today's healthcare environment?
Not really, Warren. Medical schemes in the industry pays 100% for consultations, procedures, and so on. Increasingly, we see some options go to 200% of scheme tariff, of course. But specialists often charge more than that, right? Up to 400% at times.
Or even more.
Or
sometimes.
700%. I've seen 700%.
Yeah, exactly.
The difference between what the doctor charges and what the scheme pays is where the financial shortfall lies.
Okay.
Yeah.
That is what GAP is about, is covering those shortfalls. Right?
Yeah.
And I think, it used to be that those gaps were rare, then it became sort of common. Now it's the done thing.
Yeah.
So the consumer is really left with that shortfall. So
And GAP is really to protect the consumer at the end of the day.
And it can become quite a significant financial amount, right?
Yeah,
So it's no longer, as you said, just a small, or it can be quite significant for the consumer.
Our second question, why are these shortfalls getting bigger? I mean, we've seen that. We've seen that our shortfalls are getting bigger, that we pay as a provider.
Yes, there's most probably two reasons for that, Warren. One is the rise of healthcare costs. 4% above headline inflation at times. Our analysis of a 5-year sort of claims gap indicates that over 50,000 rand increased by more than 500%, and between 2020 and 2024 highlight the growing funding crisis in the private healthcare.
Sure.
And that's exactly why GAP is there to protect that.
Sure.
Doctors' tariffs, hospital technology, specialist procedure, and rising faster than medical aid reimbursement is fundamental causes for your question.
And maybe just from your side, Doc, I mean, with your speaking to your colleagues, I mean, it's unavoidable, really.
Exactly.
Cost of technology and all that sort of thing.
Healthcare costs are going up, and everyone wants obviously the best treatments available, right?
Sure.
And in order to be able to access that type of treatment, it costs, you know, and therefore you have to be able to cover the gap.
And then, look, our third question, are medical schemes themselves under financial pressure? It's a logical question.
No doubt about that, Warren, they are. And Doc has mentioned about new technology and so on. Medical schemes are increasingly introducing co-payments as a result of the financial pressures, stricter sublimits and benefit restrictions. This is all to manage the risk of the healthcare pool, meaning that rising healthcare costs and trying to remain solvent and relevant to the member. But the gap is the gap, and that's what we cover.
Right. I'm going to go straight to question 5. What mistakes do people make when choosing gap cover? And I think this is important, because you have to apply your mind a bit when you're choosing a gap cover policy. So, Al?
Yes, Warren, 100%. Common mistakes include not matching gap to your medical scheme benefit option, because it doesn't help you having a number of sickness conditions and you want to take the lowest medical scheme, because then you're going to run into trouble. Gap's not going to pay for everything.
Sure.
Ignoring procedures in terms of co-payments, it's fundamental. You got to do that when you choose a product. Assuming all gap cover works the same. It really doesn't work the same. Forgetting policy limits or waiting periods is the other area that people make a common mistake on. So when you choose your gap, it must mirror your medical scheme benefit option.
Sure.
And you need that medical scheme benefit option. In other words, you can't just say, okay, I'm just going to get a hospital plan and add on gap. And we know people that make that mistake, right?
I mean, again, just from a legislation point of view, you can't take out a gap cover policy if you're just on a insurance-based hospital plan.
Yeah.
It's got to be a registered medical aid. So
Yeah.
Yeah.
you know, we go over that time and time again,
Yeah.
but it's so important.
And I think what Alan's saying, and Warren, you'll agree, is that the consumer must apply their mind and investigate, right?
Sure.
It's not just, well, gap is gap, which is gap, right?
Mm.
It's there are many different types, there are many different options, and the consumer must do their homework.
Yes.
Just as the medical scheme addresses your specific needs in terms of healthcare, so does your gap cover.
Sure.
Yeah.
Sure. Okay, and then the last question, is gap cover becoming essential? I think it's an obvious one, but
Yeah, Warren, increasingly so, because as a result of our previous question, okay, many advisors say gap cover is no longer an option for private healthcare users because medical schemes alone can't afford the rising cost in healthcare.
Mm.
It's as simple as that.
Yeah.
Thinking of it as a financial shock absorber for your medical aid, it's exactly the purpose of a gap cover.
Yeah.
I think that's I think those are some good questions. And now consumers would love to hear, you know, this concept of gap cover 101.
Yeah.
It's got legs. We're going to be talking about this for a long time to come. So
And I think we should also our listeners out there, viewers, to send in any questions.
Sure.
They have, as always, of any medical
yeah,
topics they'd
yeah.
like to hear, or the topic we had with exercise today, or on gap cover. If there were
Yeah.
any questions, please address those through, and we'll put the email address up
Yeah,
on
correct.
on the screen.
So I think it's another great episode. We've answered some questions. I'm looking forward to part 2 of this exercise as medicine series. And I think it's all that's left is to say goodbye, and let's listen to Gappy as we always do.
Great.
Thank you.
everyone.
Cheers.
Just
Don't stress, the gap is covered.